what you need to know and what you can do to support women and girls in your community and our community. Really excited about this one because many of our programs and pillars are weaving together an ever stronger fabric for your Miami-Dade. So, first, let's thank the people who make it happen. Not only this amazing team, um, but we've got amazing board members. We've got a lot of elected officials and community partners who work with us day in and day out. There is nothing, not one thing that the Women's Fund does alone. We work on a collaborative impact model, but also a really fierce philosophy of radical collaboration. And that's why I think it's one of the reasons we get so much stuff done. So that brilliant board, many of the members will be with us here today. I see many of you. Good morning, amazing board members. But let me specially focus in. We have four pillars, as you know. Today, the pillar we're focusing on is health and well-being. And Citrus Health is not just a financial partner, but they are a partner in thought, word, and deed. So we work really closely together. They've been our health and well-being sponsor for years. That included the work where we were able to focus on the effects of extreme heat on pregnancy, right? Working with many folks in the county, working with Human Rights Watch, March of Dimes. We've had speaker from the March of Dimes years ago, and the body of information is growing daily about what we need to do to support women who are going to be affected by increasing climate change. And so on we go. That led us to work with all kinds of other folks. And we couldn't do that unless we were supported by our visionary innovators, strategists, all of these impact partners who give unrestricted funding because they trust in the overall work and how we're all collaborating together. So thank you each and all. Really, really, really couldn't do it without you. So, as you know, we have four programs and four pillars. Usually, we take a moment to focus on our data and research at this time. We do a little infomercial here, but instead, we're doing a special infomercial with insights on our newest collaborative program. The Women's Fund considers ourselves Switzerland when it comes to AIM, Alliance for Infant and Maternal Health, as its own country. AIM has its own logo and its own enormous alliance that we are here to support. So, to give you that framework is our one and only amazing team member and AIM lead, Ms. Val Butler. Val, take it away.
Thank you. Thank you, Maria, panelists, amazing panelists for being here. And everyone that's in the Impact Collaborative today, welcome. Good morning. Bear with me. I am a yapper, but I'm being disciplined today, so I'm going to get through this on time. So what we'll be just taking a peek into today is the maternal health and hypertension insights from the Alliance for Infant and Maternal Health, and what that means for us as a project, what that means for us as a team, and in our community. Just to take a brief peek at the data that really makes us stand up and makes us want to speak out. So when we look at our state, as far as maternal death rates, we see a slight increase, right, in maternal death, which we know this is a crisis that's existing at a national level, that's existing in all types of communities. And when we look here in Miami-Dade specifically, we see actually a decrease, but still alarming rates. And then what becomes even more alarming is when we look at the disparities of this. So when we move to the other side and we're continuing to further examine maternal death rates, we see, although there's a decrease in Miami-Dade for the general population, we see an increase from 61.6 to 70.5 for Black birthing people. And the disparities like this, not just high rates, but also the disparities in access, in care, in what's being provided, in what's being evaluated and reported on, is where we see a need. As Maria often says, the Women's Fund is in the gaps and needs business. So this is where we fall into place. Not just examining and evaluating the processes that are in place, but how are we reporting on them in a sense in which we can empower our birthing people in our community to feel less at risk. or to have better outcomes when we look at the data. And then, even more so, how we can empower our community members, our brothers, our sisters, our mothers, those who we're networking with here in the Impact Collaborative, to take action and protect each other. So, when we look at the Alliance as a coalition, what we are focusing on are five main drivers. And those drivers that we are targeting are hypertensive disorders, which we'll further deep dive in today with some of our best community partners who are on the ground, providing direct services and leading the way, as well as other drivers such as mental health, prenatal care, postnatal care, and SUIDS, sudden unexpected infant death syndrome. And by focusing on these drivers, as an alliance, we bring together partners from all aspects of care, whether it's from therapy, from managed care, from Medicaid support to infant mental health, maternal mental health. Most, if not all, of our major hospitals in South Florida, and a lot of our statewide or even nationwide organizations like the March of Dimes or like the American Heart Association. We all come together to lead on this initiative so that we can see outcomes in areas and reduce infant mortality, maternal mortality, and maternal morbidity, as well as preterm births. So we look forward to keeping this project going and reporting to you all on that and seeing a shift in our community. And when we talk about hypertensive disorders of pregnancy, or specifically for this project, intervention for maternal hypertension, there are five main community action targets that, as an alliance, the coalition has agreed to prioritize. And those five I'll run through really quickly before we get started, so you all know what work is looking like on our end before you get the bigger picture of things. So firstly, we have, which one of our panelists here today will share deep insights on, the universal screening and education materials for low dose aspirin. What does that look like implementation wise? How can we empower pregnant individuals to know if this is the correct tool for them, to have the conversation with their providers, and to advocate for themselves in that lens? What does that look like? And when we look at the other four community action targets, we also see home blood pressure monitoring programs, which is another channel we see as a way to empower birthing people at home in postpartum or during their prenatal time, how they can take power into their own hands and how they can advocate for themselves with their care providers and within their community. We also will incorporate the evaluation and the examination of postnatal follow-ups and prenatal wellness checks, making sure that in that transition of care, there are no gaps. And if there are, how can we address them? How can we reduce them? And how can we work together to break down silos in the care that's being provided for individuals? And then also, we have a huge focus, which many of you in this Impact Collaborative, I'm sure, have come into contact with one of the extraordinary and impactful public awareness campaigns produced by the Women's Fund. We're taking that same energy and magnifying it to empower our community when we focus on patient, client, provider, and community education. And what this looks like specifically is public awareness campaigns that we're focusing on to keep culturally sensitive for our at-risk communities here in Miami-Dade. What does that look like? What does that sound like? What languages is that translated into to make an impact and to empower people? So that's a quick look into the Alliance for Infant and Maternal Health and what we have going on when we consider hypertensive disorders of pregnancy or maternal hypertension and the intervention needed. And I think it's such a special time to examine this because although we're dedicated to maternal and infant health 365, taking a look at this care and these disparities, especially as we transition into Black Maternal Health Week, is just such a great way to get those thoughts started and get those communities talking. So we're excited to share this time with you all.
Indeed, we are. Thank you so much, Val. And just to drive it home, every single person in this audience, and it's an amazing turnout. Thank you each and all for being here. Whether if you're running an early child learning center, you are just as important. Yes, the health leaders, the birthing community leaders of the Alliance set the goals and what we're doing for AIM, but you're the ones who are trusted. PTA parents, governmental folks, church leaders, and especially you preschool owners and teachers. People trust you. And that's what our leaders in the healthcare community are telling us, that they need you just as much as we need them. So that's what the Alliance is all about. So very, very excited to have our keynote now with us. And we're going to ask her to do double duty. The work that the Preeclampsia Foundation does is so amazing. We're going to ask him not only to give the keynote, but then to join us later in the panel. And preeclampsia is a tough word. So I'm going to ask you, Kim, to make it real for everybody in the audience. Please take it away.
Thank you. Absolutely. Thank you so much for being here. I'm Kim Gifford. I'm the Director of Healthcare Practices with the Preeclampsia Foundation, and I am also a two-time survivor of preeclampsia. My first experience was luckily very minimal. My second experience actually was with HELP syndrome, which I'll talk about very quickly here. And the next thing. So we can go on to the next slide. And thank you so much. So the definition for preeclampsia is that typically it occurs after 20 weeks gestation, typically more frequently near term. And it is associated with a collection of symptoms, but most often defined by high blood pressure. So that's the defining characteristic of it. So we'll move through these slides pretty quickly because I know we're going to be mindful of time. You might have heard preeclampsia in previous years called toxemia. That's what it was when my mother had it. So that was another familiar term. And then when I had it, it was hypertension disorders in pregnancy. So it's called various things, but essentially it all deals with different components of the body, and it could come in various severity and various forms. 3 to 8% of the population nationally is considered to have preeclampsia. Now, one of the things that we're seeing here at the foundation is that many of the providers that we work with are saying their rates in their patient populations are much higher. And there's been a large increase after COVID, and I'll kind of show you that in the numbers coming up, but it can definitely mean eclampsia, which is seizures, and then the HELP syndrome, which was mentioned, deals with hemolysis, which deals with the problem with blood clotting and red blood cells. It deals with elevated liver enzymes. It deals with thrombocytopenia, which is again clotting factors in the body. It may or may not be present with hypertension, and it can cause organ failure. So it's definitely a problem. Now here, each time you click, you're going to see one of the little red things come up. So if you kind of click through, and I'll let you know when you can stop. But when we look at overall in the nation, the causes of pregnancy-related death in the United States, one of them is hypertensive disorders. One of them, a large portion, is cardiomyopathy, other cardiovascular conditions. And this is because when we talk about hypertension in general, in any population, it damages the vascular system in our body. It erodes away the smooth lining, sticky things stick along that eroded smooth lining of the blood vessels. It makes the blood vessels weaker, more prone to aneurysms or things like that. And then one more click, you will see the fourth aspect if you just click the slide one more time. So when we talk about how prevalent preeclampsia is, it really depends on how it's been coded, how it was diagnosed in the medical record, and how the death certificates were recorded. Because it's not just high blood pressure, it's all the other associated issues that can contribute to it, but preeclampsia might have been the main cause. So larger than what we realize component of how this impacts maternal health and death rates. So next slide, this is specific to Florida. So this came from our MMRC. You guys have a lot of these data too. This really good comparison here. You can see the number one cause of death for the latest information that we have is hemorrhage, and then comes hypertensive disorders of pregnancy, which is what we're talking about today. Preeclampsia is one of them. And then you can see there are other things, but again, cardiomyopathy, Cardiomyopathy is where the heart muscle is impacted, and that is most often directly caused from high blood pressure. So even though it's listed separately, the cardiomyopathy, cardiovascular diseases, they're all likely connected, as are the cerebral vascular accidents, which are strokes, which is a complication of preeclampsia. Okay, next slide. So this I thought was really interesting because this is something that's not often talked about in preeclampsia or hypertensive disorders of pregnancy, and that is when the majority of deaths occur. And you can see that the majority of deaths from hypertensive disorders occur after the baby has been delivered. And when I say delivered, I don't necessarily mean live births. So it can be a stillbirth, but often this is when it shows up, and this is when most lives are impacted. So the next slide. Um, the percentage of preventability. This was just so striking because we talk about like the national statistics from the CDC say up to 80% of maternal deaths are preventable. This shows you that in Florida, their records show 83% of deaths were preventable. That means we have a lot of work to do in our quality and our processes and our identification of signs and symptoms and the speed of which we recognize and give treatment. So there are all kinds of issues that relate to this, but it's really quite striking. And then this is specific just for Miami-Dade. It's a little bit hard to see, but you can kind of see where your numbers have been for the maternal death rate. And again, this also came from the health indicators from the health department website. But Miami-Dade's kind of been hanging around. You see this slight increase right around 2021. That is an alignment with the national averages. That is strongly correlated with COVID. Once COVID happened, there were a large amount of maternal deaths that were strongly related or coded as such because of COVID. And it's kind of come right around where they are. But the interesting thing that I found is that for the southern part of Florida, really the values are going in the wrong direction. There's been some tremendous work made in the last couple of years, but they're still not on target. And that's different. That's a little bit harder to hear. And then, as Val mentioned earlier, that women of the Black birthing age are much more disappropriately impacted or disproportionately impacted by preeclampsia. So you can see that the death rate was almost 34% higher for Black women. So not only do they experience hypertensive disorders more frequently, the severity of those disorders is much more significant. And in some states, it's up to 9 times more likely to develop preeclampsia. Here for Florida and for the southern half of the state, we're not quite there, but there definitely is a difference. And there's a lot of things that lead into that. I think a lot of it has to do with their hesitancy to seek care, to dismiss the symptoms. They don't want to go to the hospital because who's going to care for the children that they have at home and what's going to happen to those children? So there are lots of factors that make them less likely to have confidence in the healthcare system. The other sad fact is that cardiovascular disease is the #1 killer of women in the United States. It is definitely the #1 cause of death for Black women. And that when you take a look at that population, less than 20% of them were told after they have preeclampsia, do they know that they have a risk for cardiovascular disease? And the majority of them don't. And that's something that's really impactful because we know cardiovascular disease doesn't always show up right away. It's related strongly to lifestyle. And when they're pregnant or just after, that's perfect timing to make small changes that can make a big difference in the impact and the quality of their life. So I'll pause there, and we have a great slide coming up here with a little poll, and I'll let you guys participate in that.
Yes, so that's how this rocks. This is how this rolls. It's all about all of us, like in the Greek theater. The audience is just as important as the actors and the stage. So please act, actors, here in the quote unquote audience. Many of you have been speakers here before, please participate in the polls. They do make a difference to us. Please do post your questions in the Q&A. Instead of like raising your hand, please put them in the Q&A tab. Some people text them to me, panelists. Some people will put it in the chat. I'll try and catch everything, and we'll get to as many questions as we can later. And then we also ask you, please, as soon as this is over, you will get a survey in your inbox, and it does make a difference because we iterate all the time. Things change at the Women's Fund because we listen to your feedback. So please give it to us. So I will say the next thing that happens here is we ask what is not impossible. We ask each of our panelists to introduce themselves in 2 minutes or less. And why is that possible? Because they're just introducing themselves in context of why they're with us today. And so we're going to ask our first two panelists to do that. Then we'll go back to you, Isadora, to talk about what we need to do, and Kim will join us. So we'll go in that same order. So, Isadora, thrilled to have you with us today. Please self-introduce.
Hello, everyone. Isadora Del Vecchio. I am one of the senior directors of maternal and infant health at the March of Dimes. And actually, I've worked with them for over 12 years. So I spent a good portion of my career in the state of Florida. I live in Gainesville and work remotely. And so right now, my role since around 2018 has been really focused on in implementation of our national initiatives. For the last 3 years, I'm solely focused on low dose aspirin and our low dose big benefits campaign. And I did want to shout out to Nisha Avent, who is here on the call. She is our director of maternal and child health and collective impact in South Florida, and your contact locally for this campaign and other work.
An amazing partner. Tanisha, good morning. Now, Eliana, can we ask you to please introduce yourself in 2 minutes or less? What you do for this community is amazing. Welcome.
Good morning. Thank you for the opportunity of being here and joining this amazing team of stakeholders, providers, and community partners. My name is Eliana Ramos. I'm the executive director of the Honeycomb House. We are a Miami local nonprofit organization, and we're focusing on reducing perinatal anxiety and depression and chronic stress on pregnant and postpartum mothers and babies through a holistic approach. We get together with the mothers, we teach them how to face daily life experiences in a different way. So it's an amazing opportunity for us to be here, and we're looking forward to, answer the questions. And if you guys have any questions as well, just feel free.
Amazing. Okay, Isadora, now you've got 3 minutes to set the scene. What are you seeing? What do we need to know?
So basically, I'll talk about the March of Dimes low dose aspirin campaign. I know Kim gave us that was a beautiful presentation, especially around maternal mortality and what's happening there. And just to say, right, like nationally, preeclampsia impacts around 1 in 25 people. It's a pretty serious disorder, and there's not a lot of awareness about preeclampsia or the potential solution for low dose aspirin usage throughout the United States. And that disparity exists whether it's in the clinical realm. A lot of OBGYN folks do know about it, but there's a lot of other clinicians that engage a pregnant person throughout their pregnancy who don't know about it. And then pregnant patients themselves aren't aware of preeclampsia and the warning signs and the signs and symptoms, and they're certainly not aware that they may be at higher risk for preeclampsia. And Kim addressed some of the reasons why for that already. But so our campaign focuses, because of all of these issues, our campaign focuses on we call them the 4 legs of the stool. So professional education, consumer education, public awareness, as well as quality improvement protocols. So what that looks like for us is we developed a suite of low dose aspirin focused education, really, and I might have a chance to talk about this a little bit more later, but this intervention, raising awareness of low dose aspirin, is a community intervention at its core. There are clinical components, but building relationships with trusted messengers, some of who I think were already shouted out on this call and are on this call. So people like your doulas, your CHWs, Healthy Start, community-based organizations in general in your community. I think even if you are at a preschool especially, right? Like it doesn't matter where you sit. If you're a trusted messenger, you have a lot of opportunity to help spread awareness and engage the patient population. So, including home visitors, I hope there's some on this call. They're key to this type of intervention in terms of birth worker style education and engagement. And so this is also something that happens, as I stated, there's education needed. Some of the clinical factors that are at issue include unawareness of the recommendations for low-dose aspirin. One of the biggest issues is that the preeclampsia risk screener tool that is recommended by ACOG, WHO, SMFM, and I'm missing someone, the USPSTF, that tool is not embedded into people's workflows mostly, right, in these outpatient ambulatory clinics. It's not embedded into the workflow. So often the high risk factors do get caught. People recognize those and they may choose to prescribe low dose aspirin based on the patient's portfolio of health and what the clinician thinks is appropriate. But the moderate risk factors are a little bit more complicated. There's a total of, I think, at least 15 factors, right, that people are looking at. It's overwhelming. It is hard to keep that in your head. So it doesn't exist in the workflows. That's one of the biggest issues, honestly, that we face at the clinic level. For the patient factors and issues that are there, it includes, the lack of awareness, typical things, fear of medication while pregnant, which makes total trust. And there's mixed messages about low dose aspirin. So if they go to their pharmacy and talk to their pharmacist may say, you can't take low dose aspirin while pregnant, right? So we're also hoping in the next 2 years, we have plans, not hoping, to work and focus on pharmacies and pharmacists and education, and kind of learning, how can we get them more involved? What does that look like? It's very important. And I just wanted to say, I should have started with this, but hypertensive disorders of pregnancy in the United States are on the rise. They have risen from 2015 to 2024 in the US by 90%. And in Florida, during that same time frame, they have risen 100%, folks. So we do need to work like Maria said, we really need each other right now. And if you have any questions about our low dose aspirin campaign, if you want to learn more, Tanisha Avent on this call, just go ahead and chat her right now because she can set things up to engage.
And AIM is supporting as well. So AIM, Alliance for Infant and Maternal Health, will be partnering. Just everybody, we just got shouted at. We just got shouted at. That data is incredibly powerful. So wake up calls are good. We like to be shouted at. Eliana, you may shout at us as well because we need to know what you're seeing. How do we make pregnant people even more visible and important?
Well, yeah, I know the news and the information that you guys have shared is really shocking. And the call for today's, at least my mission, is to ask you guys to ask the right questions. Because we get pregnant and postpartum mothers in our offices, clinics, daycare, childcare centers, and yes, we are targeting the condition. We know that they need to take the aspirin dose, but we don't ask them the right questions. Do you have food at home? Do you have health insurance? Do you have any support? Anybody that you can actually talk about it? Do you have a safe place and a closest friend to place to your house where you can go measure your high blood pressure? Do you have any food at home? What type of food are you eating? Because, for example, we can get them into the OB doctors, or we can get them in the postpartum care appointments, and those moms, sometimes they don't even have anything to eat. Or what they eating is what they can grab in the supermarket that most likely is the cheapest products. And that's also increasing the high blood pressure. Sometimes they don't even have the equipment to measure themselves at home, and they don't have transportation to go get it done. So my call today is all of you as service providers to ask the right question. It's not, are you taking the pill? Are you taking the aspirin? That's not a right question. The right question is asking for those stressors, assess for those needs that those mothers are experiencing out there. That's number one. And the secondly is just to help our mothers, our clients, our burden mothers to advocate for themselves. Because sometimes, like Isadora said, they might go to the pharmacy and the pharmacy might say, oh, you shouldn't be taking an aspirin dose during pregnancy. But if we have an educated mom, a mom that is aware that she's being informed about the condition that she's experiencing and the greatness of the treatment that she's getting, we're going to have a mom that is going to talk to the pharmacy and say, this is what I need because I already know what is good for me in this specific time. So those two are my main messages that I would like to send all of you. Ask the right questions to those mothers, because that really it gets the gap even bigger for us, that we are working collaboratively as a team to get results done. But if we don't meet where the clients are, we're not going to get there.
Yeah. And I think one thing that Eliana focuses on at this point now is one of the same things that surprised me as one of our most successful outcomes in the Alliance for Infant and Maternal Health. And it's creating space to have those conversations of where we merge the effects, the social drivers of health with the everyday care. And what do those two experiences look like? And what does that space look like when we have care providers from a full spectrum of care having these conversations? How are we addressing houselessness? How are we addressing stress, and how these things are affecting hypertensive disorders of pregnancy? So
Thank you,
having that
Val.
examination from the full scope, I think, has made such a huge difference.
Thank you, Val. Exactly. Kim, do you have a minute just to give us anything else you want to add to what you're seeing? And then we'll now go back to solutions for all three of you.
Yeah, there's a couple of things I'd like to add. The first one is that there's a lack of knowledge, I believe, in the providers. They may know aspirin is recommended, but they don't know how to communicate best to the patients why. There's the timing. There's a very narrow time frame of when it is recommended. It's between 12 and 28 weeks, with 16 weeks being the most ideal. There's a lack of knowledge of, do they continue it through the entire pregnancy, which is what ACOG recommends, or do they stop at 36 weeks? There's a myth of what aspirin does is that it increases the risk of breathing and bleeding at delivery, which there's no evidence to demonstrate that. And I just had the privilege of teaching a group of about 100 doulas last night with Dr. Conti Ramsden with King's College of London. And one of the big things that came up consistently was, I don't want to take a medication in my pregnancy. This was a huge thing that the doulas are hearing. And, part of it is poor communication about what medications are and the risks. We've heard communications from experts that state you shouldn't take even Tylenol if it's, unless you're dying. And there's just so much misinformation. So I think it starts with the providers. I think it starts with better research, which I know that there's definitely some good studies going on about the best dose and appropriate dose. And all of that just needs to get communicated. But the one thing I think we need to just let patients know is that every woman is at risk of preeclampsia. If you're pregnant, eventually you're going to be at risk. Your risk level may vary, but you're eventually going to be at risk. And so you need to ask the provider, is this something that would be appropriate for me and my plan of care?
That's perfect, because that's what the Alliance members were very clear about. They're very interested in this campaign, and we will be working with March of Dimes on it, but they wanted to make sure that all pregnant folks and the people who care for them ask their healthcare provider and come back. Tell us, Isadora, you've got a lot of solutions. What can we do? 3 minutes or less, please.
Yeah, so I would say I'm trying to think like what's the most important piece because there's so many. We really do think all four pieces have to be addressed. So we have an e-learning module that's free and accredited for professionals. I'll provide Maria and crew some of these resources. We have developed with our partners at the CMQCC in California an implementation toolkit for clinical teams. How do you go about doing a low-dose aspirin quality improvement project? Focus on increasing your screening rates of the preeclampsia using the preeclampsia risk screening tool. And then, what does it look like to actually prescribing low dose aspirin? Kim, thank you for Also shouting out for clinicians this piece about the 36 weeks. It is a thing around the country. I hear it often. And so really ACOG's recommendation and SMFM recommend taking it through labor because we don't see a bleed risk. Understandably, that's a concern for people, but it's time to really dig into all of this and think differently about it. I'm not going to say the numbers off at the top of my head, but a lot of people, a lot of the 3 million births in the US qualify for low-dose aspirin, right? So like for instance, if it's your first pregnancy, that is a risk factor. You already have one, right? It's a moderate risk factor, so ideally you'd have 2+, but that's just like the numbers of people are large. Low dose aspirin is safe. It's low cost, no cost. Most people or many people have access. I will say some people don't have access. So back to Eliana's points about be sure to be in conversation with your patient. They may not have access to low dose aspirin. They may not be able to afford it. If they're in Florida Medicaid, though, there is a $25 um, monthly stipend. If people even know about that, they could potentially use it to make the purchase. But knowing about your benefits, I think we all know is difficult. And I don't know mine for my health plan, for instance. So the clinical piece is really important, the education for the patient population. All of our consumer materials were really made to empower the patient around what are the risk factors, knowing your risk factors, asking your physician, is low dose aspirin right for me based on these risk factors? And if not, why? And if so, why? Like patients, I'm hearing from women around the country, they want to know why. Don't we can't just screen them and say you have 3 risk factors or you have 1 high risk factor. Like they might need to know more, especially if it's not diabetes, or they still might want to know more, actually, is what I'm hearing from the patient population. They want to really understand the background of why you're prescribing this because of the fears around taking medication during pregnancy and the misinformation out there. And so, the other piece is the clinical workflows. I can't understate, like, it is so important. We just launched our first cohort at the March of Dimes of a quality improvement initiative, really focused in Texas with Texas clinics, New York and New Jersey clinics. And we're pretty excited about that. It will have a cohort next year as well that will be starting. So just shout out to any clinics on the call, contact us if you're potentially interested in doing a quality improvement protocol. I think it's really important that we set up those systems properly, that clinic level providers are able to pull the data on their risk factor screening and preeclampsia prescribing. Adherence is another thing, folks. But we do find with proper engaged shared decision-making style education and engagement with the patient population that adherence rates go up for LDA over time. We have done 3 cohorts of this work in California, so it works. This is an intervention that works. It is, I don't like to say simple. Building workflows and EHR are never simple, but at its core, it is a simple intervention. It's doing the screening tool and prescribing. And then the public awareness, which we're working with AIM with as well. And we have other projects like New York City, the Bronx is running the campaign, and then also we'll have South Florida and Houston, Texas running the public awareness. That's important because, like I said prior, this is a community intervention. The community, the public at large, needs to know about this intervention. They need to be able to point to a trusted national messenger like the March of Dimes or AIM to say, actually, this is who told me about it. So let's learn more together. Because when someone is prescribed low dose aspirin, it's not just them, their partners, their aunties, their grandmother, their mother. They might tell them to stop taking LDA, right? So we need to combat that with this public awareness and community awareness and knowledge with the goal, right? The ultimate goal is, to provide information to all of these folks so that it's just an embedded norm, right? That we know that this can assist with preeclampsia prevention.
Amazing. Eliana, there's so many incredible folks in this participating in the audience today, some amazing communicators, great experts in culturally competent care, and you are a lead expert here. Tell us more. What can we do? What do you want people to?
Well, now that we understand the situation, Now that we have all this evidence-based being done, we know what to do. Next is collaboration. We talk about collaboration all the time. We talk about, what everybody's doing. We know what everybody's doing most of the time, but sometimes the referrals, they fall through the crack. So we don't have the mothers connected with the services that they really need. So the next step should be just referring to the right place. I already assessed for this mom that is going through a preeclampsia situation, or she's pregnant, she's postpartum. Okay, I can refer them to Health Star, or I can refer her to another community organization, or I do have a list, for example, of the community partners and resources that I can allocate for this mother, and I'm gonna make it happen. Sometimes we need to walk the extra mile with these mothers because they going through so much with little help. Just imagine how difficult pregnancy and postpartum is for a woman that has a stable job, family support, basic needs cover. It's hard. So imagine being in the same pregnancy situation without all those resources. It's difficult. And I guess I take it to the next level because I'm hearing all the time all those needs and how hard it is for them to get to the right place, to the right program, to the right help. So now that this opportunity has been given to me by the Women's Fund, the next step is collaboration in first place. Collaboration in mind. Okay, I can refer this mother to a free health clinic because she doesn't have insurance to cover. I can refer her to the next food distribution site because she doesn't have fresh food at home and she's eating what she can. Or, she's having issues because she has a child with special needs, complex needs, and she needs help at home. So that's the type of collaboration effort that we really need locally to get these mothers to the next step, to the next stage of life.
Well said, Eliana. And note to the team, we have the YWCA super involved and ready to act, and Overtown Children and Youth and all kinds of other folks, but we need the YMCA as well. It's really about everybody supporting as well. So, Eliana, our pledge to you is that will be a very, 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 very continue to be an ever-growing round table of people to support. Dr. Catherine Toms is in the audience, and she posted before Green Cars for Kids about some kind of transport as well. There are a lot of amazing humans in Miami-Dade County and South Florida that we can plug into. Thank you so much for that. Kim, please tell us your calls to action before we go to the Q&A.
I think one of the easiest and least expensive items that we can do is, thank you for that slide, is the use of a postpartum wristband. As I showed you in the slides before, the majority of deaths occur after a delivery. So delivery is not the cure for preeclampsia or hypertensive disorders. It extends 6 weeks postpartum. There are a lot of wristbands in the nation. Florida has, I think, 5 different colors just in Florida alone. But there's 2 things that set the initiative that we're behind apart. Number one, hypertension in and of itself, with or without pregnancy, often has very vague or no symptoms at all, which is why it's called the silent killer. So while you could be at risk for hemorrhage, a woman is going to know if she is bleeding heavily. She will not know necessarily if her blood pressure is at an elevated risk. Additionally, the level of blood pressure for a pregnant woman is much lower than what it would be for the average individual. So that threshold being smaller means that she's likely not to even know. She just may feel crummy, but you just delivered. You're going to feel crummy, right? So what we have done, and I am so excited to say, I just got back from DC in the last week or so, but Health and Human Services, American Medical Association, American Heart Association, and Premier are all on board with this still at risk wristband to let moms know, number one, that they're still at risk for death after delivery. And secondly, that it is a strong connection to cardiovascular disease. That's why the little heart is there. So it gets that conversation going with the doctors. If we can nationalize or harmonize one color, one message, this means that if a woman is in Miami and she's up here in Brevard, where I am in Florida, and she's visiting and she goes to my county, which she doesn't want to be in right now, they're going to identify, EMS is going to identify, and the ED physicians are going to be able to identify that this is a woman who needs to go straight to labor and delivery, not to the ER and sit there for hours, and not to the stroke unit, which has permissively higher blood pressures. There were 2 women just in my county alone that died because of this last year. So it's definitely a really easy fix. It's inexpensive. So again, I'm excited to say that we have this initiative, and there'll be training around EMS personnel and physicians in the hospitals as well as clinics. That's huge. Someone also mentioned self-measure blood pressure at home if they have access to it. That's a really easy thing because blood pressure can change dramatically within a matter of hours. So when having that cuff at home is really a valuable tool for women. We've talked about aspirin, and then of course the education, not just providers, but for patients as well. And the one thing that we're seeing in our focus is now moving into community health centers, especially knowing that there is that 4th trimester, and even the American College of Cardiology recognizes that pregnancy is not, it doesn't end with delivery. It really should be, and mom's health should be considered above and beyond. And just like Ileana said, it's a whole person aspect. All of these things that put women at risk for these high-risk pregnancies, being overweight, not being healthy, being advanced maternal age. Some of them are within their control and some of them aren't. So helping them be healthy overall is important, and teaching them stress management for those families that are exposed to violence in the home or substance use or something else. It's all part of the picture. We can't fix it all once, but these tactics that are listed are very easy and typically inexpensive.
Amazing. So, call to you in the audience here. Call to funders. There are action items that we can do here with AIM. Can you imagine? So here in the house, in the audience today, we have Southern Birth Justice, we have the doula networks, we have Mount Sinai. Good morning, doctor. We have lots of folks from Baptist, folks from UM. Can you imagine all of these clinics and providers, doulas, midwives, hospitals, clinics, all being aware and having access to everybody who touches them to have that one color bracelet. It's not that expensive, but what if we invade all of Miami-Dade in collaboration together and see what can happen? These are possibilities, and that's one of the reasons that we have AIM. Sorry, Kim, go ahead with your next slide.
Oh, yeah, no, this was one tool that we also have. It's called My Health Beyond Pregnancy. It talks about the things that the primary care practitioner, which is a huge component of women's health, or the midwife or whoever she's seeing following up afterwards, can discuss and make sure that the right information is documented in the chart, that she's aware and that she knows what to do to impact her health. And I did see a comment about A1's bracelet. It is on there. It's a post-birth alert. It's all comprehensive. It doesn't draw attention to any one risk that may be more hard to distinguish than others. So there's lots of options out there. But like, as you said, just having one color standardized is going to help reduce that risk, we believe. So.
Amazing. So we're going to go to the Q&A. I'm going to ask you all to include morbidity because we've been talking about mortality. It's easier for people to relate to somebody living or dying, but somebody feeling good or vital or just at a certain percent of their capacity for, the next 10 years of their life needs to be addressed, and we need to get more fluent in that, be able to understand a little bit what morbidity and feeling good is. First question, and this comes from one of our wonderful Alliance members, Leah Janetti from ICU Baby. And that question is, if the risk for mortality and morbidity is highest after birth, why would low dose aspirin stop at 36 weeks or at birth? Does the literature not support this? And I think we'll let you go first, Isadora.
I was going to say maybe Kim should go first.
Oh, good, better.
But we're
Kim,
probably going to say the same thing. So, but
Kim.
Well, one of the points of contention about the 36 weeks versus delivery is that there is no evidence that once aspirin is continued beyond that, that it is effective. And I think it's important to highlight that aspirin is not necessarily a preventive tool. What it does is sort of delay the onset, is what we believe, and may, in some women, just sort of get them past that threshold so it doesn't develop at all. So if they were more likely physiologically to develop it at 34 weeks, perhaps they get to that 40 weeks without having catastrophic symptoms. So, but that's the reason why, and the mechanism of which we think it impacts and lowers the risk for developing severe symptoms of preeclampsia or at all is because it's just not impactful past that 36 weeks. Isadora, please feel free to jump in.
yeah, it's basically there's not scientific evidence, and so it's not recommended currently. So the March of Dimes follows ACOG, CDC type, recommendations. I will say, anecdotally, I know it happens around the country. So some physicians are prescribing straight through. That is their choice as a clinical provider to do so. But there isn't evidence. We have a literature review on postpartum preeclampsia, and even just that, Kim, correct me if there's not as much as I'd like to see, based on the data. The data tells us we need to know more about that postpartum period, and that's why I think working with outpatient ambulatory clinics, especially FQHCs, and community clinics around the country is so important because, you know what? After people leave the hospital, they're kind of right. What I say is like women are dying in their homes, folks. They're going home and they don't even know there's a problem. And so that's another reason why community matters so much because it really, Eliana pointed this out, right? Connects that continuum of care because they're not dying in your hospital and they're not dying in your clinic. They're dying in their homes. So how do we make sure that how do we offset that? And it is these like other shared interventions, including wristbands, which I think is an important low cost piece of it.
Making women and girls visible, right? This is part of our work. Eliana, anybody can take this one. This is a really essential question and core to the reason why AIM was even formed initially. So this next question is, do the numbers reflect for women of more affluent backgrounds, especially Black and Hispanic women in Florida? I hear the conversation mostly focused on low-income women here, but I have seen that the care for more affluent women with insurance to have also less options and doctors to be more closed-minded when it comes to care and options for delivery. This is a real thing, is it not, panelists? Eliana, do you want to address this first?
Sure. Definitely. Colors matters. It does. We are located in one of the most low-income neighborhoods in Miami-Dade County, and we are connected with Liberty City and Little Haiti, where we are expanding the scope of our services, and we can definitely see that Hispanic Black mothers are mostly affected by all these type of issues during pregnancy and postpartum care. Solutions, the summer go-getter, and that's the vision, right? Bring the resources to these neighborhoods. That's the goal. Just bring the education. We are having a maternal and infant health fair in Liberty City next month, because we want to bring all this education and these resources to the mothers. Because whether we see the increase in Black mothers having all this type of chronic conditions, if we educate these women, if we distribute the information to them, if we let them know that there are resources, there's things that they can do, they're gonna go find that help. So I believe one of the bridges that we're facing in our community is distributing the information in the right places. So yes, and that's our mission. Our mission is to bring all this education for pregnant and birthing mothers and their children, because that's something that Isadora said that it needs to be remarked. During pregnancy, we're focusing on the mother. And once the baby is born, the baby becomes the celebrity. We have to take the babies to the pediatrician's offices, right? And then the doctors are focusing on the baby. And doctors are not asking the right question. I keep saying this because with my professional experience for over 10 years in a local hospital, that's one of the awareness I always discuss with physicians. We have to ask these mothers the right questions. Are you eating? Are you sleeping? Do you have support at home? What's going on with you? Because baby can't talk. Babies cannot talk. So babies become the celebrity. And then that's one of the reasons. Of course, I don't have the research at hand, but I have the experience for over 10 years sending those mothers at home without asking the right questions. And then we're going to see those moms in the postpartum appointment 6 to 8 weeks after.
I think another point that I wanted to share in just thinking on that question is that, so from our end, those of us who are in the work, we know that the maternal health crisis affects women, birthing people, regardless of what your socioeconomic status is, geographically, wherever you are, you can still be affected. The reason why you see this emphasis on Black birthing people, Hispanic birthing people, is because that's where we see these disproportionate numbers jumping, and where we see areas of reduction through education, through community care, through research advancements. We are not seeing the same reduction in those communities. So that's kind of why you see that emphasis a lot of times. And then I think also we see that same disparity when we look at educational materials and resources. Whereas here in Miami, we think of what that diaspora looks like. Whereas we may have thousands of handouts, videos, YouTubes, TikToks, Instagram reels, everything, how to educate yourself, empower yourself. We may not have that in Haitian Creole, or we may not have that accessible in other areas where maybe not everyone can, pass by daily or visit this office daily to receive this information. So I think we see those differences when we focus on those disparities and seeing it in the data and in real life, what that looks like. And that's how this response comes about.
There was a comment in the chat, Raisa, thank you very much, about really culturally competent care and having a doula, midwife, be able to be that great communicator with. We have Southern Birth Justice and many other educators here who are in the audience with us, and that is, even though a lot of, and Cortez, you can correct me in the chat if I'm volunteering you all for too much. Also the Black Mother Cares folks from FIU, they have an amazing program. So there are resources here. So whether the Southern Birth Justice is giving the direct care to clients, or any one of the other providers is reaching out to Southern Birth Justice to do a training with them, or the Black Mother Cares program, there are ways to, educate ourselves and to have everybody get closer and closer to culturally competent care. Having Serena Williams is the easiest one to say, how famous can you be? She knew her body and she really had to fight for her own rights to have people listen to her. So we're getting to the end. We might be able to get to Leah's last question, but let me say before, because we're almost time out, and maybe we will come back with one question, so don't leave us yet. We have 4 pillars. So not only